Hello and welcome to the highlights postcard summarizing the key messages from the recent webinar, Advancing Patient Care Through an Interdisciplinary Approach to IMIDs. My name is Herve Bachelez. I'm professor at the Department of Dermatology of the St. Louis University Hospital in Paris, France. I'm joined by Professor Tim Orchard and we'll summarize the great webinar that we had with Professor Ian McInnes. And today we will provide this highlight summary of the content discussed in this very webinar. The highlights will include some clinical pathogenic pathways, including the immunogenic pathway, and also the rheumatologist, dermatologist, gastroenterologist trigger and its implications as a matter of interaction and in practice, interdisciplinary management in IBD and psoriasis, not restricted to the patient care, but also as for innovation. To access the full on-demand webinar and detailed discussions for individual speakers, head over to www.imidforum.com and watch for free. So what we learned is that there are some pathways, inflammatory pathways, belonging to elements bridging the innate and adaptive immune system, like for instance TNF-alpha, which are canonically engaged in different inflamed organs. So that's, for example, the case across psoriatic arthritis, rheumatoid arthritis, ankylosing spondylitis for joint conditions, but also inflammatory bowel disease, both in Crohn's disease and ulcerative colitis, and in skin inflammatory disease for psoriasis, hidradenitis suppurativa, to name a few. And TNF-alpha is really a prototypic example of these canonically engaged cytokines. On the other hand, you have even inside a given disease entity, like for instance spondyloarthropathies, you have some patients responding to TNF-alpha blockade, other responding to IL-17 blockade, and other responding to JAK1 inhibition. Emphasizing and reflecting the fact that there are some inflammatory mechanistic scenario which are heterogeneous across different subsets of patients, and skin diseases are no exception, because we have some patients with psoriasis who are responding to IL-23, IL-17 blockade all along, and others who are early relapsers, and they don't follow obviously the same pathway. Also, and I will end up with this, we have to take into consideration the immunological switches that we are inducing when we use the targeted treatments, like for instance TNF-alpha blockade in some patients is upregulating the type 1 interferon pathway, leading in some cases to paradoxical reactions. So this is quite apparently complex, but there has been a lot of advances in this field, and we are just at the beginning of a new era, importing these private versus publicly engaged inflammatory pathways in the disease taxonomy and the stratification of the patients. Professor Orchard, Tim, would you like to rebound on that for your expertise, main expertise in the field of inflammatory bowel disease, which is a disease much more complex than the dermatologist thought it would be?
Thanks, Robert. I think you've summarized it beautifully. I mean, there clearly we have that interesting mix, don't we, of public pathways that appear to span a range of IMIDs and are really good pathways to tackle from a therapeutic perspective, and then a subset of private pathways where treating them will be effective in some forms of IMID, but not all of them. And I think we heard from Ian, as always, beautifully expounded how that function works. And I think we saw some very interesting examples looking at the regulation of how IL-17 and IL-23 interact in their pathway, and how there are differences, meaning IL-17 probably has a significant role, for example, in maintaining the constitutional functions of the gut. And so therefore, we now have ample evidence that IL-17 blockade in inflammatory bowel disease is a deleterious thing, whereas we know that IL-23 blockade is highly effective. However, if you flip to axial spondyloarthritis, it's very clear that IL-17 blockade is highly effective, and IL-23 blockade, for whatever reason, is much less effective. And we had an interesting discussion that at the end of the day, it's not entirely clear why that is. And I think that that's a sort of quite a neat example. But even within sort of specific IMID areas, we know that different patients, for example, with inflammatory bowel disease, will respond to different advanced therapies, suggesting that in individual patients there is a primacy of one pathway over another. And at the moment, we don't have mechanisms of being able to predict in advance which pathway we should be tackling in which patient. And of course, that has to be one of the key aims of personalizing medicine as we move forward.
Exactly. Absolutely. Thank you, Tim. I think we were all agreed that the future, in practice, because our audience might think that this is really sci-fi, that we are thinking really out of the blue, but there are already some examples, starting with the the rare single gene models. They exist in IBD, they exist in rheumatological conditions, inflammatory disease. They exist also for psoriasis, and they show that you have a start of integrating, in this case, some immunogenetic biomarkers, which are really orientating the prescriber right away to the prescription of some targeted treatments rather than others. And I think that this probably is something which is announcing a lot of groundbreaking discoveries in the precision medicine. What also I like very much in the Ian McInnes presentation is also the reference to the microbiome, and that's that's of course where I would like to have an exchange with you, because you mentioned of course microbiome is crucial in IBD. And at the same time, in some other disease like skin disease that you refer to hidradenitis suppurativa, which where there is an increased risk of IBD, but also of ankylosing spondylitis and spondyloarthropathies. We still use, and this is still in the guidelines, some antibiotics, and sometimes in the long run, which are obviously disturbing the gut microbiome. So that would be a sort of question exchange with you. Do you think that this is really something that should belong to the past, based on the crucial role of the microbiome perturbations in the pathogenic scenario in IBD, or should we de-dramatize the use of some antibiotics, at least on the short run, or even on the long run? That's a question for you, I guess, as a matter of, because this is, I think, something which has some impact in practice for the prescribers.
I think it's a very interesting question. I think there's good evidence that if you look back before people's inflammatory bowel disease has been diagnosed, there is an increased risk of inflammatory bowel disease if you have had courses of antibiotics in the preceding period. So I think there is clearly a clear role for environmental triggers of inflammatory bowel disease. I think the interesting question is that it is not entirely clear at the moment whether those microbiome disturbances are important primarily as triggering incidents to start the inflammatory disease, or whether they are then important in perpetuating inflammation thereafter. I mean, certainly there have been some interesting trials of fecal microbial transplantation in inflammatory bowel disease, and they're interesting primarily, I think, because one of the sort of leading trials was about to close down on the basis that it was entirely negative. They allowed the last few patients to go through, and suddenly the trial flipped from being negative to positive on the basis of a single donor. So the sort of idea of a super donor sort of then emerged, and it is clear that there are particular aspects of the microbiome that are important. The problem at the moment is that it is very difficult to manipulate the microbiome in such a way that you can think about how it will have impact in a therapeutic way. And of course, one of the targets, of course, would be to be able to manipulate what is effectively the external environment. I mean, the gut microbiome, in order to damp down the inflammatory response. But I think it is clearly important. I think at the moment we have so far lacked the tools to manipulate the gut microbiome. But with every passing year, all the new techniques around microbiomics, metabonomics, and things like that have helped us to understand both what's in the microbiome and whether it's the microbiome itself, or, for example, the metabolic consequences of that particular microbiome that are triggering the inflammation.
Exactly, and I'm glad you mentioned that, because my next comment was that obviously there is also the metabolomics that should be invited to this multidimensional approach, because we know for sure that some different diets they have some impacts on the innate and eventually adaptive immune system, sometimes on the long run, depending on their components, and so there is also the indirect effects of the microbiome disturbances. Thank you, Tim, for the very relevant comment. Maybe we could also comment something that we just touched on the surface, which is how, first of all, do you believe, and do we believe, that we have enough IMID centers in UK, France, wherever, or should we consolidate some kind of reference IMID centers that would really network with all the practitioners who are engaged in the management of patients with the IMID conditions? And I'm not speaking only of the hospital practitioners, but also in the liberal practice. I mean, that's a very practical question, and the reason why I'm really importing this in the discussion is that, for instance, in France, we don't have any formalized IMID center in any university hospital. For me, it's extremely frustrating, I have to say, because of the comorbid conditions, because of the need that we need to exchange on a daily basis. We need to have multi expertise around one given patient, and also, of course, to stimulate transdisciplinary research. So I would like to have your comment both on the on your perception in UK, and which is probably a little bit more, this concept is probably more developed in UK from what I saw than in France. But how do you foresee the present and the future of some IMID centers?
I think that there are a small number of IMID centres largely in big teaching centres in the UK. I think that there are quite a lot of hospitals where there are sort of joint clinics between sort of two specialties, but possibly not between 3 or 4 specialties of interest. And I think it's and I think we're not very good at sort of identifying the population of patients who would benefit from that multidisciplinary input. And I think, you know, so if you take inflammatory bowel disease as a sort of a baseline, well, sort of my baseline, there is a group of patients who will have an large joint oligoarthritis that's associated with active inflammatory bowel disease. If you treat the active inflammatory bowel disease effectively, the oligoarthritis settles down. It's a non-erosive, non-deforming arthropathy, and then it's essentially settled. And it's so closely linked to the inflammatory bowel disease, there's probably not a lot of benefit to getting a whole load of experts in. But then on the other hand, you will see patients who have presented originally with erythema nodosum, then they develop a peripheral and axial spondyloarthritis. They may then develop things like erythema, pyoderma gangrenosum, and all of those conditions can then become chronic, and you then end up with a very complex scenario where you need to think really carefully about what treatments and what combination of treatments is most likely to influence those multiple conditions. And then, of course, you get back to those interesting questions about which public and private immune pathways are you trying to influence by your different treatments. And I think those sorts of patients definitely really benefit from that sort of multidisciplinary approach or interdisciplinary approach. And if we can corral those patients into centres where they have a proper IMID centre, I think it's probably better for the patients. B, it really allows a much more focused research effort on the most complex patients. But even if you can't get to that point, I do think there's a really important point that around you could arrange local services to make it easier for rheumatologists and dermatologists and gastroenterologists to interact simply by thinking about where and when you are all seeing your individual populations of patients, so that even if there isn't a formal centre, you have an informal mechanism of being able to sort of have that conversation about difficult patients.
Absolutely. I guess we have the same issues. I like the joint clinics and the prospects and reality because it simplifies also the patient's journey in the daily practice. But if we don't have that, yeah, I mean, I guess that through video meetings and we can also interact and to discuss the difficult to manage cases, and that's something that happens a lot in the tertiary care centers. So I guess for me, and if we want to summarize, I think we are just at the beginning of a new era where the better understanding of what is the hierarchy of the different inflammatory players in a given group of individuals with the same clinical pathological entity as a disease between brackets, and this is something that applies again across the different specialties. I think is a fantastic delineates a fantastic prospect and future for a new disease classification where we keep, of course, the description of the old masters and the alive, but we import and we reshape this entity in view of the understanding through functional genomics, the transcriptomics in this case, but also the immunogenetics and other biomarkers, the metabolomics, of course, and also understanding all the immunological switches that might happen in real life. So that's something that more and more, again, I'm absolutely convinced that those who believe that this doesn't belong to their circle, they should really come and hear and re-listen to this podcast, and also dig deeper in the literature, interact, go to the IMID Forum website, and really, I'm sure that they will be convinced that they belong to the same family as ourselves. Tim, I leave you the conclusion for this highlight summary. I think we had really a great highlight summary. If you want to add something before we wrap up.
No, thanks, Herve. I mean, I think it was a really excellent discussion with Ian around both those very interesting pathogenetic issues, isn't it? And that sort of move from the clinical description of diseases through to a mechanistic description, which will allow us to then work out what the right treatments are based on that classification, which I thought was a really interesting thing. But also actually some of the very practical things about what can we do now to make sure that we identify IMIDs once we know that we've got a patient with one condition, that we can identify other conditions and start to think about those early, so that we can intervene early, because we know that we see a lot of patients who, for example, have silent gut inflammation while they have spondyloarthritis, and have silent sacroiliac inflammation, certainly, when they've got inflammatory bowel disease. And we know that if we can pick that up early and get it treated, we are probably going to give people a better long-term prognosis. So it was a fascinating way to think about what we know now and what we should be aspiring to for the future, I think.
Fantastic. Thank you, Tim. And I read between your lines that we will move very soon from early intervention to early tailored intervention through the identification of the key players across different patients' population. So we hope you found this highlight summary useful. Please remember to visit www.imidforum.com to have access to a variety of contents, and to keep an eye out for future webinars. Thank you for your attention. Thank you, Tim. Thank to Ian, and thanks to the team, and I hope to see you soon. Thank you.